Hi everybody and welcome back to the Doctor's Lounge with myself, Dr. Imad Alauddin, Dr. Sajjad Ahmed, and with us today we've got a very special guest, Dr. Abdullah Albeyatti. He's a GP down in Leeds, but he's also a very close friend from university days, and well, more impressively, he's also the CEO of Medical Change. I'm going to let him explain about that when we get to it. But today we're going to be talking about the future of IT in healthcare, which is something quite topical, but then we're going to expand and see where it'll take as well. So first of all, how is everyone?
Yeah, not bad. Good.
Yeah, very good. Coping well with the lockdowns that come on and off.
Yeah, so obviously you're north in Leeds, Ab, so I don't know if you've been affected by this new partial lockdown in the area you're in, or is that just outside where you are?
Just outside. So it was basically in Leeds and surrounding Leeds, everywhere went into lockdown. So like Calderdale, Huddersfield, Manchester, Bradford. So everybody around us apart from us. But they had it on the news, I think yesterday, the day before yesterday, said Leeds is getting pretty close.
Okay.
And a lot of my family members live in Bradford, and they've told me nothing's really changed despite the new instructions.
I think it's quite confusing, isn't it? Because people don't. The thing I've always found is the information has just not been disseminated properly from a central point to other parts of the country. So people are confused as to what it is. And obviously in Wales, we had different regulations, but no one really knew what was what. So that's is not really ideal. But I think it is what it is. I think you have to lock down some areas, but there we are. Before we send into a big COVID discussion, let's move on to what we're going to be trying to talk about, which is IT and the future of IT in healthcare. Now, well, I say move on from COVID, but before we do that, we have to say that the way that we're now consulting in GP practice, and now also you're seeing it more in hospitals during the COVID pandemic, has changed drastically, as we mentioned in one of the previous podcasts. And we are now relying a lot more on technology to do these things. And we're going into a lot of virtual consultations, video consults, e-consults. And actually one of the things I wanted to talk about as well with you, Abs, is one of the platforms that you designed, I think whilst you were on quarantine isolating, was a platform called My Clinic, which is to do with video consults.
Yeah, so it's kind of like a double-edged sword for me, this whole lockdown, the way we've embraced technology. You know, on one side, it's fantastic because it's well overdue. And, you know, I think we should have been using this tech from, I mean, if we're being honest, a decade ago. You know, there were things called Skype and other kind of MSN Messenger and whatnot that's been around for donkey's years. So I'm very happy that it's kind of a worldwide pandemic has dragged people into the future. The sad thing is, you know, that we're trying to do all this kind of consultation, remote consultation, and trying to get clinicians used to using it as well as patients in the middle of a pandemic. And that's not ideal because, you know, people are already quite anxious, already worried that they're not getting the right level of care. So I hope if we learn one thing from this pandemic, and we'll learn lots of lessons, I'm sure, one thing we can take from it in healthcare is, look, try the new technology. Don't be dismissive and think your patients won't get it and they won't understand how to use it, so we won't even try, because it would have been great if we all practiced years ago. So when it came to this pandemic, using this kind of tech is just second nature to us.
No, exactly. And for some reason, I've always found that the NHS and IT just don't make something that it should be quite straightforward. If you look at what we're like in our day-to-day life on phones, video calling, family, etc., etc. But as soon as you step in the hospital, it's pages, fax machines, and just outdated technology that nobody uses outside a hospital, and it's remarkable.
There's quite sort of a very interesting aspect, because I was thinking about as you know, as Abdullah said, the pandemic actually bringing on the IT on us and forcing it upon us. So we are actually now consulting through videos and pictures. But I was thinking, because when I was training in a hospital, we were using paper notes. Hospitals were not completely PACS ready, so the radiology x-rays, you used to have it, sort of hold it with your hand and have a look on the white box. And everything was written on papers, and we used to carry a big trolley, paper notes along us. Now things have changed a little bit where the computers have come into the hospitals. When I came to GP training, and when I was doing GP training in the UK, it was all computerized. So I was thinking today, when was it first that actually GPs embraced computers and let go of the old George Lloyd style notes or the paper notes or the file? Because we still have paper notes in the surgeries,
Yes.
and you can see them in the bulks and bulks and bulks. And sometimes we dig into those and find these old typewritten notes from the 1960s and 70s. And I was actually reading a paper, and it said it was mentioned in the one of the National Library of Medicine journals that the British general practitioners use the sort of the computer systems for consultations around more than 30 years ago. Mm-hmm. So if you're starting something 30 years ago, you're probably talking about 1990s. Why the sudden stagnation? I mean, it took us 30 years from using a computer to actually going onto video platform. That's very slow, isn't it?
Yeah, I mean, I think it's multifactorial. So I remember being a patient or a child and visiting my GP. They used to have the kind of MS-DOS screen, if you remember. And it used to come down the side and you choose like option 1 to 4 if you wanted prescription, acute prescription, whatever it is. And they used to just, hammer their way through. And then you've got systems such as System 1 or EMIS, which I am sure at the time when they were deployed were considered cutting edge. For us that use, those two big systems, whether there's Microtest or Vision, for example, I mean, these systems look like they're Windows 95 now. There's been no update, no integration, no need to do it. And frankly speaking, it's because they monopolize the market. If I had a system which 50% to 80% of the country is using, why would I feel the need to innovate? You're all using it. You're all a slave to my product. So why am I going to spend millions renovating this product when you're all happy to use it as it is? And, when I say it's multifactorial, I think that's one of the reasons. I think the other reasons is, as clinicians, in this side of our practice, we are very technophobic. And I've had many, many meetings with many doctors, which, just make me shudder when we have those conversations, the stuff they say to me. I can give you one example. I was trying to talk about our products, one of them being myclinic.com, to one of the doctors. And I said, look, Abdullah, we've got 10 partners in the practice, and we gave all the partners a double screen so they can see their notes on one side and open Google or whatever they're doing on the other screen. Out of the 10 partners, only 2 could use it because 8 of them kept losing the mouse between the 2 screens. And when you work,
this is, I mean, if you look at general practice and the history of general practice in the 1950s, it sort of became integrated into the national service. And GPs have worked always independently as partners. The first GP who actually implemented a computer system was called John Preece. And that was in 1970s in a place near Exeter. So this is an initiative by a single GP starting to use computers in the 1970s. I mean, in the 80s, I had a Commodore 64, playing machine. I don't know what sort of computer he had in the 1970s to actually implement it in his practice, So you're saying about GPs losing the mouse in between the 2 screens. That's quite interesting. I mean, we obviously need to move forward.
Well, it's painful. And then if I want to be fair to GPs and I want to be fair to doctors, I don't want to be just GP bashing, since we're all GPs here as well. It's that GPs and doctors as a whole have been let down by technology many times in the past. Many times companies have turned up and said, we've got this brand new shiny thing. It's going to solve all your problems. Take 2 weeks to learn it, integrate, do these passwords, and then they crash, they fail. The bill was into the millions. I mean, you just have to look at, for example, the track and trace COVID app. I mean, how many millions have they spent on that? And within the space of 6 months, they've already binned it. And people talk about millions like it's just coming from the air. Like, this is taxpayers' money. This is, this is unbelievable. There needs to be some accountability when these things go wrong, and who made the decision to proceed in this direction. So I think when you have these kind of factors at play, it's an explanation as to why tech in health has been so slow. But I hope, I really hope we do have a new motivation in terms of the business side of health tech. Is absolutely booming. It's one of the fastest growing areas. A lot of angel investors and family funds are going into this area as well, with VC funding as well, because people can see that this really is the future, this idea of removing borders between patients and doctors and improving the way that data flows between them as well. So we can only hope that we don't take backward steps.
So do you think whose responsibility is it? GPs are independent. So do you think it's bound on individual GP practices to actually take the lead and transform their business and spend their own money?
I think that's what happened. You mentioned that the practice when you went in had changed and it was all computerized. That was GP practices working on their own backs when they had the new QoF contracts. I'm not sure what year that contract was. So one of the GPs was telling me this. He was saying, well, the government didn't think we would be able to meet the QoF targets, but we improved our systems, we improved the IT, we used computers to monitor what we had to do, and that's what pushed the GP systems. And even now, I'd say there's much more IT system in the GP practices than in the hospitals. My dad he's 70, but he's going into the clinics, even he's doing remote clinics by the phone. I was like, Dad, why do you just do it from home? He's like, oh, because they haven't got the notes. The notes are all paper notes in the hospital still. To this day, they're paper notes. And even when I was an F1, they were still doing paper discharges to go home with. These little flimsy things where you try and write on, and the third copy you can't see what's there because it's one of those carbon paper things. And it's only recently they started doing digital discharges. And it's so that's the other thing that I think does play a big part. It's coming back to the contract issue. One of the big issues we have with the NHS is very politicized. So you have one government starting a project, spending millions of pounds investing in an IT system like the NHS Spine. And those of our listeners who don't know what that was a system where you have all the records in one place, a centralized database of patient records where people can access to certain degrees from anywhere in the country. But then you had a new government come in and they said, oh, it's not worth it, we'll scrap it. And they wasted millions and millions of pounds on this IT system that in theory would be a great idea, but in order to try and politicize the NHS, which every political party does to win votes, they'll come and change it every time someone else comes into power or a new government is in place. So GP practice is a little bit protected from the hospital environment because they work slightly more independently, so they can update the systems. But I think the government influences play a big part, especially in hospital medicine.
Yeah, so you talk about the spine. You say millions. It costs 12 billion.
Yeah. No, I understand.
Billion. Like, what can you do with 12 billion pounds? And I think this is the problem that you say who's responsible. I think from both ends, you've got central government, which is responsible, and you've got clinicians responsible for different reasons. Central government are responsible because they need to justify how they spend. And from the other side, from the clinician side, they have to say, look, we want these things, we need these things. They need to do more of a demand, more of a push, and we need to be the advocates for our patients. I think it's not fair when you go to one practice down the road, which is cutting edge, and says, look, you can have access to your records, you can book an appointment through the app, you can do this. And another practice down the road just goes, yeah, we don't do that. That's not acceptable, for those patients. When we have to be the advocates that's helping them, the barriers in terms of how do we adopt these kind of technologies, again, it comes down to the government. I can give you an example. There are many things out there called frameworks. I don't know if you've heard of frameworks, but when you go to purchase a product, it has to be on a framework. And there's so many frameworks out there. And as talking from like a health tech background now in my health tech company, it takes you like 4 to 6 months to fill out the paperwork and go through all the hoops to be put on a framework. Then you find out this framework covers this, but not this. So start the process again to do this one, and then this one, and this one, even though they all really overlap with each other. And when you go to a practice, so for example, there are some practices which are very, innovative, and they want to take technology on board. They'll say, look, Abdullah, if we want your tech, we have to fund it from ourselves. if your tech is part of the framework, then NHS England will fund it. So you start developing this kind of two-tier system where you might actually be superior to everything's out there. But if you haven't jumped through those hoops and ticked the boxes and the other kind of, in my opinion, shady things that happen in the NHS, you're not going to be on the framework. And if you're not on the framework, no one's going to be able to purchase you, or you won't be awarded those contracts. So there is a barrier as well from central government in terms of getting this technology out to the practices.
So who's
well,
managing,
speaking about
who's sort of managing the frameworks? Who is in charge of the frameworks?
It's officially in the UK, it's officially NHS Digital. They should be in charge of the frameworks, but there's like one called DPS framework, Dynamic Purchasing something framework, which we're on. So we're an approved online consultation software. You would find our company on there. We're in a list of 30 others which are approved by the NHS to be an online consultation provider. G Cloud. Then there's another, it just goes on and on and on and on about getting onto these frameworks. And it's not once you're on this one, you'll be automatically copy and pasted across all of these. It's you need to answer the 180 questions each time with each of these. And some of the questions are very, very intrusive and unrealistic. So they will write things which are very geared or tailored towards big, well-established companies such as your EMIS and your TPP. They'll say, what was your 5-year account history and what is your 5-year account forecast? Okay, if you're a health tech startup, you don't have a 5-year history and you don't know what your 5-year forecast is because you're just burning all the money that you have in reserves to build your product. So there really is, how do I put it? If you are in the system already, it's a very comfortable system to monopolize it. If NHS comes out and we want open source, open access, you can't have locked in systems where this system doesn't talk to this system. We're EMIS and the records are locked in EMIS. We're system one and they're locked in system one. No, it has to be open. You have to communicate with each other. They can say all this narrative, but practically they're not doing it. Hospitals don't talk to each other. Primary care systems don't talk to each other. Physios, social workers. There's so much in the system which digitally, electronically, it is not a challenge. It's very easy to fix. But the bureaucracy that comes in there, and for certain people, they don't want to change the system for their own benefit. It's a great system to survive in because nobody's going to be pushing you out anytime soon.
Well, I think we've talked a lot about what the problems are and kind of neglected what we're meant to be talking about, which is the future. So let's try and redirect a little bit. But it's a good background to understand for people who don't know much about IT what the challenges are to try to implement new systems. So about these frameworks, obviously not having a company myself, I'm not going to know that. But from your point of view, the barrier to entry seems quite high for anyone who's not familiar with it. I think you're right. The big companies have been around a while. For them, they know what they're doing. It's easy sort of to get on all these frameworks and then become established and then stay there and occupy that space, preventing people from coming in. But it can be done. And as you said, and I want to mention a little bit about your enterprise, the medical chain. And I think that's touching a lot of things we talked about. I think reading into it a little bit before today, the idea came about from discharge centers, is that right? And then there was the aim to make patient medical records, decentralized and then actually in the hands of the patients rather than centrally in the government. And that way people can give access to whoever they need to, and therefore it becomes more accessible and it links in quite easily with whoever needs to see it.
I mean, you summarized it all, so I don't need to say anything.
I wasn't sure because I still haven't got my head around mining and Bitcoin stuff. It's a little bit confusing, but I know it's based on that blockchain technology.
Yeah, I mean, the blockchain side is, frankly speaking, it's irrelevant. For your common day user, they don't need to know that. They just need to know that this is being held in a very secure manner. It's accessible in a very secure manner to the point where you are able to disrupt the way that we practice medicine. And that's what I'm a real advocate of. And I think healthcare is going that way anyway, but whether it's going to be 5 years, 10 years or 50 years, I don't know. But, we've all got our smart devices. We have our banking details on this. We have our emails. We have our photos. We have all our personal information. But for some reason, we don't have real access to our medical records. And I don't mean some kind of, you know, haphazard primary care. You can see some stuff. I mean, the way you and I see it in the practice, where it's very clearly, these are my attachments to my documents from the hospital. These are my test results. This is the narrative which has been written by the GP. Because I think the way we have to disrupt healthcare in the future is removing these barriers, improving patient choice. And the only way we're going to do this is if the patient comes to the clinic and goes, this is who I am, scan my barcode, you now have access to my records. I do my looking up, investigations, I don't need to unnecessarily repeat tests. I can see all your allergies, save, done. Thank you, I've got it back on my phone. I now fly to Spain on holiday. I break my ankle in Spain. Here's my medical records, scan, yep, I can see that. We're gonna upload your x-ray there so when you go back to the UK. Thank you very much. And I'll go to the orthopedic doctor. Not as we have now, oh, where did you come from? Sorry, I can't see that. Oh, you've gone to A&E? Sorry, I can't see that. You have an x-ray? Call the PACS team and ask them for a CD and maybe you can get it in 3 weeks. And again, you know, what I'm saying to you now, you know the tech exists. We already do this. How many WhatsApp messages do we fly between us and upload documents and save this and store this and chuck this on the cloud here? So why can't we do it in healthcare? You know, and I think one of the reasons or the barriers was that added level of security. How do I know the patient has not tampered with the information? How do I know the patient hasn't deleted something or altered something? As you have in a lot of apps, as robust as they are, there's too much flexibility for the patient to write, I've had an MI, I take bisoprolol, and they just input things manually, which might not necessarily be true. And I wouldn't feel comfortable going on the information that a patient inputted themselves, bar their allergies. So the kind of tech we use is what's going to secure that. So, you know, when you're looking at that information, it's as if you're sat in the practice and you're looking at exactly the same information their original or normal doctor would be seeing.
And that's something that's quite interesting as well, because I remember reading an article saying that at the moment with medicine, it's all very reactive. So you're going to see the patient when they're ill, and that's when they normally come in. However, trying to change that practice to make it more as a monitoring, as a proactive situation. And by doing that, you need really good technology. So you'll be monitoring patients more in real time through the use of apps that they can get on their phone, or through the use of, now the big thing is wearable technology. So you've got your Apple Watches that can look your heart rate. You can get, well, I'm not sure how reliable they are, but you can get these, even these apps which will try and measure your pulse if you put your finger on the camera. From that point of view, I think there is a lot of potential there for doing remote consults like we're doing now with the video stuff, but then also getting actual physical patient data coming through as well. I don't know what you guys think or what your thoughts of that are. Would you rely on patients recording their own observations, for example?
Well, I'll give you an example of the out of hours. So in Cardiff, where I do out of hours, I won't name any companies, but the out of hours software that we use, I mean, coming back to what Abdullah said, patients often ring in and say, you might see on the computer that I've had this. And I say, well, no, actually, I don't have your notes from your GP, because the software that we use, and which is used, I think, UK wide, doesn't actually have any links. Or even if there are links, often they don't work to the GP notes. So we don't know what's going on, what medication they're on, what illnesses they have. So it then depends on your skills, and you are taking the history from the patient to find out what they've had done. Often they wouldn't know. Sometimes they say, I've had an operation, I've had a scar in the middle, I don't know what they did. And you're sort of assuming, and it takes me really back to the third world countries where when I was practicing in Pakistan, we used to say, okay, he's got an appendix scar, so he's had an appendectomy. The patient wouldn't know that they've had an appendectomy, but you would assume that because the scar is in the right iliac fossa, it's probably what it was done for. And hence, so a laparotomy wouldn't necessarily be, you know, for something else. You wouldn't know what it was done for. So these are very challenging issues. Taking notes from the patients, I usually ask them, for example, if they say my heartbeat is racing, I say, can you tap on the desk? Can you tap on the phone? Your heartbeat? And that's sort of the rough idea of what's happening, and that's only for triage purposes. With telemedicine, I think the challenging comes is if you can see a patient, you can more or less do a lot of through how they are feeling, etc., through the camera. But what's lacking is the listening to the chest or feeling the tummy. I don't know how we can substitute that electronically. I mean, sure, Abdullah will enlighten us on that.
No, I think I agree with you. I don't think it's a golden bullet, and I don't think it's an ultimate solution for everything. But it's very good at triaging serious things. It's very good at, I think, lowering the workload on GPs by understanding who actually needs to come into the practice and who doesn't. So there's many practices I've worked at where there's a blanket, if it's a child, they're getting the same day appointment. And when you see the child, and I've seen this before, the child literally cycled into the practice on their tricycle. It's just like, this was a complete waste of an appointment. And all it needed was a video call to see the child in the background doing a handstand. And you say, okay, look, this can wait till tomorrow. In terms of abdominal stuff, by all means, I think it's down to the actual doctor's skill. It's like a PR. Some doctors are going to get more information out of the PR than other doctors. But again, for a baseline, I want to see your child jump up and down on the spot. If I can see your child start doing jumping jacks and everything, it's not an acute appendix. That's fine. I'm okay for today, and we can wait later on. So there's little nuances, but by all means, there's lots of patients that just need to come in, need to be physically examined. There is technology out there, as you say, Ahmed, that lets you listen to their heartbeat, listen to their auscultation sounds of their chest, otoscopes that you can use looking in the ear, you can have a look in their mouth. I think the thing that we're missing probably in our, not just generation as doctors, but generation of people as a population, is there's a real hunger and a real capacity to be educated. And I think the patients want to be educated. They're thirsty to be educated. When we were practicing at Imperial and training before together, we were taught it's a very paternalistic medicine. I say, you do. I know, you don't know. And even when we spoke about patients bringing sources of information, it was always looked down upon. They're going to bring you some rubbish article from Google. They're going to bring you some hippie rubbish from America. That's not true anymore. You know, when we're working as doctors, it's a teamwork. I'm there to advise you clinically. And when patients go, I'm really sorry I Googled this, I go, you shouldn't apologize. I'm really glad you did. What do you think it is? I think it was gout. Okay, let's have a look. Yeah, you were right. Did you see what treatments there are? Actually, you know, this one wouldn't be suitable for you because your kidney results were this in the past. So we go with this one. So our roles as doctors are to offer patients options and let them know what their options are. But I don't see why they can't do a lot of recording, why they can't do a lot of journal. You know, when we write them to ask food diaries, when we ask them to record their own blood pressure at home, I think as doctors or as a healthcare profession, we should push more and more onto the patients. We've become too much mollycoddling, too much come in, let me see you. You had one day of runny nose. You hurt your toe. Yes, no, push back, monitor yourself, look after yourself, go online, reassure yourself. If it's not better in 2 weeks, come and see me. And I think this is where people are missing the attitude that we should have with technology. Technology is not about creating more workload for the doctor. It's about letting the patient feel more reassured. They measure themselves. They got a quick phone call. It wasn't a 1 hour drive to the doctor's, half an hour sitting in the waiting room, 5-minute chat with the doctor, 20 minutes waiting at the chemist. It takes the whole day up. And what are they going to do with childcare during this time? Instead, put the kids in the corner. Look, I monitored myself. These are my symptoms. What do you think? 5-minute quick chat. Okay, I've sent the prescription electronically. It'll be in your doorstep tomorrow. Thanks very much, doctor. Goodbye. I get back on with my kids.
Electronic prescription is the sole subject in Wales at the moment.
What's going on in Wales? Why is this such a problem?
I have no idea. They're not even close apparently. It's still going to be a few years before they get up.
Wow.
But again, it's just people and IT. It's a very simple solution to implement, but because of the bureaucracy and the political infighting between, I'm not going to name too much, but some health boards, should we say, or some bodies, it's just taking a long time to implement. But I think you're right, Abs. the idea of making patients more responsible for their own healthcare is something we really need to be pushing and advocating more and more. I can't remember which country it was, but I'm thinking it's Germany. I could be completely wrong, but they actually have their healthcare records, like you're saying, with medical training. They actually have their records on a file on a USB, and whenever they see a doctor, they give that, and they're responsible for that file to take it with them anywhere. But in the same way that you have responsibility for medical records, having responsibility for your own health, putting things into apps that you might even then have a GP who can look at the details or the input from the apps, not obviously the full stuff, but in a form of a chart or some summary of the information there. For example, you've got patients who check their BMs, and if they put it into the app and it goes to the GP surgery, you can see actually, okay, this patient's sugar is fine, or you can see, no, these are quite high. And it may just be an alert that comes up on your screen to say, yeah, doctor, you need to have a look at this patient. His BMs are not in control, or they're dangerously high or dangerously low. And that will then suddenly trigger your attention before you're dealing with a patient with a severe hypo, or even in some cases going too high the other way, and then you're dealing with a DKA or something.
And I think COVID has been great for this in two senses. In one sense, this idea of pushing back against the patients. You know, when you have a unified line and we all say there is no referral to the hospital, I cannot see you, all the patients got it straight away like that. They stopped calling, they stopped turning up. There were some people who should have been calling and should have been turning up, and they're the ones that we have to go out and reach and say, look, this doesn't include you. If you're really unwell, you need to seek medical attention. But for the vast majority of people, it went away, you know, and people just looked after themselves and took care of themselves. And now you can see with kind of lockdown easing, the attitudes have eased as well. And the same kind of, you don't want to label them as time wasters, but ones which use up a disproportionate amount of the GP services are now all back. Whereas we should keep this line and say, look, I'm sorry, you don't need to see me. There's other patients that need to be seen. There's only so many hours in the day. So I think it worked really well from that sense. This idea of pushing back on the patients, it demonstrated they do listen and they are happy to take care of themselves. And last of all, again, coming back to the tech element, they're not going to be able to use a mobile phone. They won't know how to attach an image. They won't know how to do a video call. They got it straight away because they realized if I don't know how to do this, I'm not going to get medical advice. And I always liken it to the example of grandparents. You know, oh, they don't know how to use a mobile phone. Have you seen grandparents with WhatsApp and children's photos and videos of their grandchildren running and playing? They all know WhatsApp because they realize if they don't get on board, they're going to miss out on lots of videos and photos of their grandchildren. So people get on board when they realize this is the only solution available to them. And it's only going to be if we offer them a real solution, which doesn't limit the amount of care they're receiving. But at the same time, we push back, and there's got to be within the narrative of, you need to take care of yourself. If you need me, I'm there for you. But you need to take care of yourself first of all.
I think that brings me on to neatly something else I wanted to talk about, which is the population that's used the NHS the most, which is the elderly population. And yeah, there is a stigma attached to elderly populations that, well, if we do everything via technology, then you might exclude or limit the access that they have to the services because for some reason they can't use it. And in some cases that is true. There are some elderly patients who won't be able to adapt to new technologies. And there are some who will, and who have family who can help them pick it up. But there have also been lots of advances in technology trying to help patients who are elderly and how they can manage their health as well. So I don't know, there's lots of things now where you have alerts, medication alerts for patients who have got an alarm or an alert to say, listen, it's time for your tablets. And in places like Japan, they're really pushing forward with robotics, as Japan only do. I was reading that they have a robot that will actually help lift patients out of bed and take them to rooms and things. Obviously very expensive at the moment, still being trialed. And also having these companion robots that will be at home with patients who perhaps are living by themselves, perhaps isolated. And not only will they give them alerts like medication and whatnot, but they'll also act as a social companion. A lot of times, I had a patient quite recently, she's elderly, I think 90 years old, lovely lady, but she was calling the surgery every day with this problem, that problem. And one day they just sat down and said, listen, how do you feel in yourself? So, doctor, I'm very low. I said, why is that? So I don't see anyone. I'm in lockdown. I'm elderly. I can't go out. I used to go to this social club every day and talk to people. Said, okay, fine. So at the moment, if I got someone to come and talk to you, because there's volunteers groups, there's COVID volunteers groups in the community, to come and talk to you just as a social element, would you like that? I said, yeah, Doctor, I'd love it. So I actually knew one of my friends is organising one of the community groups in our local community. So I passed the details on, and they got some a young girl to go and speak to her every day. I've not heard from her for weeks. The medical problems have completely evaporated. It's not that she had. There are some, obviously, there are things there that were genuine medical problems, but there are some things that she's using as a gateway just to have some social interaction to speak to the doctors. And that's a big problem, particularly in this COVID period we have had with a lot of elderly patients being disconnected. And a lot of elderly patients still will want to see us face to face. I think the biggest demand we have from patients wanting to see face to face appointments is from that population of people who aren't comfortable. They can use the video potentially, but they aren't comfortable using it. They prefer the old system of having that interaction, whether that's because they're used to it or whether that is because they're having more of a social element to it is difficult to say. But I think that's a big role, especially at this time when some patients, and I'm not sure if robotics and things is the answer or whether there are other solutions out there.
Yeah, I think at the end of the day, if for any great technology to make an impact, and you know, we use the word technology very broadly here, you know, because it's not just software, it's physical technology, as you talk about as well. You have to start somewhere, and you have to accept there's no black and white. There's a big gray area in the middle where you need to, you know, get used to this technology and let that transition period occur as well. So you can look at it from both ends of the scale. You've got the very, very elderly and frail who really can't use video calling at all to save their life, despite how much you try or the carer helps them or whatnot. Fine. I always bring them in. So even now with COVID times, I bring those patients physically to the clinic, or I go and do a home visit for them because there's no alternative and they really are isolated in terms of receiving healthcare. And the ageism isn't just on that side about them not understanding healthcare. It's on the other side with the children who are being born right now. Why are we not starting electronic health records for children today? You know, the idea, the technology I was telling you about, you know, we have to draw a line in the sand and say, look, from day one, there's no more Lloyd paper copies. There's no more stuff. This child from day one, every child from 2020 is going to be digital. Because these guys will eventually become 30, 40, 50, 60 years old. And we can't keep blaming the older generation, go, oh, but, you know, they're paper notes. Okay, they you know, speaking frankly, they're going to go. What are we going to do about the new generation? You know, somebody who's only 18 years old and the only thing they've got on their health records is a couple of vaccinations. Okay, digitize it. They've only got a few vaccinations. Now's the time to get in there, digitize it. So going forwards, they have their medical records. You have to do this transition period that I speak about where there'll be a little overlap, obviously, for maybe 10, 20 years, but the dividends, which is going to pay off, is going to be huge in the future. That's how we built railways. That's how we built roads. You know, we did roads up and down the country. Oh, 6 months, 1 year without a road. Okay, but for decades, we drove over it afterwards. You need to go through that growing pain, if you will, and it needs somebody centrally, government-wise, to say, look, this is a stance we're taking. We can offer both services, but come whatever decade it will only be digital, and you need to get with the program, and that's it.
Yeah, but I think you need the appetite for that. You need the political appetite for that, and that's where you've got challenges coming in. You need someone to say, listen, yeah, this is what's going to happen. But the problem is with that approach, and the way the politicians will see it, is then potentially you're going to upset a huge number of portion of people that may vote for you over a certain age because you're saying, no, you can't have this anymore. But in the long term, you're right. You put the hard yards in now, and it's going to benefit everyone. Can you imagine a system where you have interconnectivity between all the hospitals and all the notes are readily available from patients? I can see them here, or they can see them in A&E. That's one of the biggest bugbears. You've got patients who get discharged from hospital and you don't really know what's happened. Even with electronic discharge, it's not completed properly. It's all very user dependent as well. And that's something we need to train our own staff and clinicians to do, is to learn to use the technology in the correct fashion. But I think if it is in place, it'll improve patient care, which is basically what we're doing and what we're striving for endlessly.
Yeah, I mean, it's you know, the idea, like you said, prevention is better than cure, and you said, how can we aim for that? And I think, I don't know about yourselves, but there's many times where the patient will come in for an appointment, and all I have to do is open up their records, turn the screen to them, and say, look, your neurologist said if this didn't work and this didn't work, we would have tried the third thing. So before we do that, do you want to try the third thing? Yeah, I'd like to. Okay, fine. You didn't need to come in for that. It's just because you didn't see the clinic letter. You didn't.
Yeah.
You know, you're not a medical professional. You're not going to recall all the terminology, but the plan was clearly there in place. And I think that creates a lot of anxiety. It creates a lot of worry. It creates a lot of tension. It creates a lot of waste in the system. Whereas if the patient could see their letter, it'd be such a much more productive and fruitful conversation if the patient says, doctor, my letter from the 19th of September 2019 with neurology said that I should move on to, I don't know, nifedipine for my migraines if the sumatriptan didn't work. Oh yeah, let me check. Yeah, I can see that too. Yeah. Did you want to give that a go? Yep, sure, cool, done, finished.
But even if you've got patients who are maybe stopping medication, so there's some people who, for example, on dual antiplatelet therapy that you're going to stop, for some reason it doesn't, and I've had patients who have been on it for several years more than they should have, because someone's not had an alert or something's not set up the system correctly or not noticed that they should be stopping this medication on this date. But yeah, having that there, even if it's like an app form, is well, actually, on this date you have to stop this medication, and then the patient will come and tell you, so, well, doctor, I should stop this medication at this point. But yeah, I think the technology is there. It's just about now trying to utilize it in a way that's going to be. It's hard because at the moment you think, yeah, it's quite easy, simple to do, but you want a system that will support that in a way that will work for everyone. Does that make sense?
Yeah. So again, you know, we try not to name too many names, but there are contracts in place. You know, when somebody's awarded a contract by the government, there are contracts in place which stipulate certain criteria. One of the criteria will be you need to be accessible, you need to be open, you need to integrate with third parties. At the end of the day, the whole motive is to benefit the patient and benefit the clinician that's trying to support that patient. The problem is the way things are worded and the lack of incentives mean that these companies don't adhere to their obligations. And I'll give you an example. If you and me have a contract between us, okay, so for example, Sajjad is the government, Sajjad awarded me the contract. Sajjad gave me £1 million for the contract. My budget, probably 900,000, my profit margin is 100. Then you come along and you say, oh, can I integrate with you? Can I do so-and-so? Okay, but my profit is only 100,000. I didn't factor in that you were going to come as well. Yeah, but you know, your contract says you got to help me, blah, blah, blah. Okay, fine. What do you need? I need a cup of tea. Okay. I'll make you the worst cup of tea you ever drank. It tastes like poison, but it's technically a cup of tea. It cost me £1.50, or not even £1.50, it cost me 1 penny. There's your cup of tea. You go and complain to Sajjad, you go, what the hell's this? The guy's meant to make me a cup of tea, he made me this. Sajjad says, look, he's done his contract. And I'll say, I have no incentive because, to be frank to the big companies out there, the amount of time Sajjad has come to me and said, oh, but we want this. Oh, and do this. Oh, we got this crazy idea. We want this. We want this. We want this. We want this. Okay, where's my profit margin? I'm now just doing more work than what we agreed to. And I'm going to do the least I can to just tick those boxes to get you off my back so I can get on with running my company. So this kind of open discussion and frank discussion, it needs to happen at the top level. I'm not privy to these kind of discussions. I know that some companies, and I know in Wales you had examples of this, where big electronic health record companies were slapped very hard on the wrist and told to go away. And these things need to happen nationally. You know, somebody needs to sit down with these bosses and say, this is it. This is the last chance. Let's start fresh again. Whatever we agreed isn't working. What is it you need for you to deliver this? What is it that you need to deliver this? You guys need to work together. I'm giving you 5 years. If you don't sort it, I'm choosing one of you. And that's going to be the whole national system. And we're sticking with this guy. And I'm giving you both a fair chance. You know, it needs one of those kind of tough conversations to happen. And I think that takes leadership. And as you say, there's no government that's in there long enough. Well, the Tories have been in, you know, over a decade. But there's not been one focused enough, I suppose, with too many crises over the horizon to just focus on our health system to actually optimize it the way that you and I know it can be.
Fine.
I hope that analogy makes sense.
No, it's a very good analogy, and I think
Yeah.
it does sum it up quite nicely. The pitfalls of having, although the NHS is wonderful, and I wouldn't have any other system as an alternative. Well, maybe tweak it a little bit here and there, but the fact that someone who needs any treatment can get it on the NHS, there are some deficiencies to it, but it's a great system. But one of the things that you have to accept with that is that political influence on it, and the fact that people will use it as a political tool, because it is, in many patients and voters' eyes, is a very emotive subject. It's how to manage that and how to get the right leadership at the top of it to try and force through positive change with regards to implementing technology in a way that is going to benefit everybody.
Yeah, I think I'm confident things will change. Like, don't get me wrong. I wouldn't want you to leave this conversation thinking I'm pessimistic. I'm confident things will change. And I think the only reason they're changing is because light is being shone onto this subject a lot more than it was before. I think there's a lot more demand from clinicians. There's a lot more demand from patients. I think as technology is outstripping in lots of other fields, in communications, in financial, everything else, people are now looking at healthcare and saying, okay, what are you guys coming with? What are you bringing to the table? So I'm really confident things will change. And those conversations need to happen. And I hope, for your podcast, if this is what you're hoping to get, is a bit of insight into what happens, then I hope I've shown that and not just made people want to go self-harm after this conversation.
It is a very good insight, actually. And I was just thinking that perhaps from this side of listeners or doctors or all of us, really, I think we should be lobbying our MPs and telling them or writing to them that they should really be looking into this. With the onset of COVID, I mean, cycling lanes have suddenly appeared out of nowhere. Overnight, we've got video consultation softwares coming around, and we are using them. Picture messaging has come, e-consult has come. So a lot of these things are, they can happen very quickly. There's no doubt about that. I think we just need to push and ask our MPs, say, look, when are we moving to the next phase? Electric cars, nobody would have thought about. I was thinking yesterday, Toyota came up with the first hybrid, and then didn't produce an electric car for decades until Tesla came, and now suddenly everybody's in the game. So I think it takes one push, somebody to see that this can work, and then suddenly everybody wants to come in. So yeah, thank you very much for coming today and having a chat with us about this.
It has been very insightful. It's been very insightful, because obviously you're in the industry, so you know a lot more than I do to just use this stuff at the end. But I think it has been very useful. It's not all doom and gloom. I think, as you're saying, it can change. All it takes is one event or something that may force the change, or even one pioneer that breaks through that can change the whole field. You had that with Apple iPhone, for example. They bought out the iPhone, and then suddenly all the phones are now touchscreen, and they're all made the same. It's just all it takes is one company like Tesla, and then you can have a game-changing principle. But hopefully it's not. You want it to be an environment which fosters innovation and creativity and technology, and that, I think, is where some of the issues are. That environment is not in place. It is more of a restricted environment, and it's hard to get that innovation involved. But I think that's coming. I think it is coming, and I think you're right, COVID has enabled that a bit more, because you're in a difficult situation, and in difficult situations, people get innovative, people get creative, and that's what's happening right now.
Yeah, I think the saying is adversity creates innovation or accelerates innovation. I was going to say that the difficulty we have in the NHS, or not specifically the NHS, but some kind of free social system, regardless of which country it is it comes down to who is the payer. You talk about electric cars, you talk about the iPhone. I'm a consumer, so I'm going to vote with my feet, and I'm going to say, I want that car, I want that phone. Then everybody, as you said, is going to pile on because they realize that's what the flavor of the month is and what the mode is. When it comes to a social system such as the NHS, it's a one-stop monopoly healthcare system where we don't really have a choice. Unless in our droves we go towards private healthcare and start demonstrating we don't want our national health service, which I think would be a terrible, terrible thing to do. And I'd never recommend that. How do you, as a non-payer, influence the system. And I think that's the biggest challenge. You know, we talk about all the tech we spoke about now. A lot of the people that are going to benefit from this tech is the patient, but the patient is not the payer in the system. They're not the ones we really focus on. We focus on the quaff points, audit trails, coding, maybe a bit of the GP, the doctor's time, and making them more efficient so they can do more larger volumes. But the patient, you know, even though we give all this chat, patient-centered care, blah, 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 the patient really is the last one we think about. How could this system be improved for them? Because they're a non-payer. So I think that, again, you know, how do we influence the system so we do make it in the favor of the person who actually doesn't financially contribute to it as much, or have such an integral part in making the system efficient, such as the doctor, the coding, the quaff, and the money that comes with it?
I think the tack will be different there, because it wouldn't be, obviously the patient is not paying for it, but they're utilizing the service, and that is costing money. So essentially what you want to do is make them utilize the service in an efficient way that's going to be more cost effective. So for example, my wife's been working on a virtual fracture clinic, and they have some of these around the country already. And the idea of the simple fractures, they have a video consult with the GP, not the GP, the orthopedic surgeon, sorry. And then they've got this whole catalog of physio videos that they'll signpost them to, and they can use the physio then to rehabilitate themselves. And then it means less patient contact in terms of having to come in and see an orthopedic surgeon and then they're now freed up to see the more complex cases. I think that's the way we're going to have to push it. So listen, this is going to be more effective for you because it's going to save you money because X, Y, Z will happen with terms of patient contact. Or this patient, instead of having, going back to the diabetes example, instead of coming in for a DKA, which is going to cost you however much money, by monitoring the BMs at home with an app, you can prevent that from happening. And it's simple technology and it's quite easy to implement. So I think that's the way you're going to have to push it.
Yeah, I think the narrative has to be really clear. And I think the business case model has to be clear as that, because even then I would hear the business case of the orthopedic surgeon can see more people quicker. I don't see it as the patient didn't have to drive, didn't have to park, didn't have to wait. Nobody's interested in how it benefited the patient, even though it does. And you're right, it does. But I think for the powers that be and the commissioners, very rarely when you put a business case together, you write what is the benefit for the patient, because that's not going to change numbers or money. Yeah. You need to say more got seen, quicker got seen, less waiting time, and then the patient benefited from all those financial gains. Unfortunately, but that's how it is at the moment.
Yeah. Fine. So I think we had a quite lengthy conversation actually, but it was good. But technology is such a broad aspect; we could be here forever talking about it. I think it's a sort of natural way to try and bring it to a close. So thank you for coming on. Well, I'll give you your full title, Dr. Abdullah Albeyatti. You're welcome to come on again if you wanted to.
Always, it's my pleasure. Thank you very much.
Always happy to have people come on. But yeah, so yeah, thank you everyone for listening at home, and we'll see you again next time.